Alright, so in this video I'm going to be presenting on the myofascial meridians or anatomy trains. So this is a holistic map of the body. So we're going to start off talking about fascia because that is going to be the benchmark and the basis for everything that we talk about going forward. So it's good to have a good understanding right now. So fascia is connective tissue inside the body, and it's what helps bind all the cells in the body together. So over here on the right, this is a picture of myofascia. So we have muscle over here, and then in between, it looks like almost like spider webs. And anytime you open up the body and do a dissection, you're going to see this surrounding everything. So when we first started dissecting into the body, you have to cut through the fascial layers in order to get to the muscles. So for a long time, the fascial system as a whole was neglected in terms of anatomy, and the view of the body that we have now is very westernized and industrialized. So we think of the body as pulleys and levers, and that's how we've been taught in school, and it's gotten us a very long way. But what we're gonna talk about in this presentation is the lost sort of form of fascia and how that lets us see the body in a different way. So when I'm telling my patients about fascia, a common thing that we hear is fascia is the saran wrap over the muscles. And I think that's a good basic way to view it, but it's sort of limited in its view. So I like to think of fascia as like the white stuff that's inside of an orange when you peel an orange. It's all over it. It's in between each segment, and it's holding the structure of the orange together. So if we think of the actual like fruit as like the bones, and then the skin around it might be the muscles, the fascia would be the white stuff that holds it all together. So fascia actually has more innervations than muscles, specifically like sensory innervation. So it's rich in proprioceptors, mechanoreceptors. So when we are feeling sensation inside our body, feeling pain, when our balance is off, a lot of that time we're focusing in on our fascia and we're feeling through that. So developing a strong fascial system is important in terms of regulating our sensation. And the fascial system is what connects all of the systems in our body together. So it's not just around muscles and bones, it's around all of our vital organs, and it's interconnected. So you can think of this big, gluey spider web matrix inside of our body. It allows everything to function interconnectedly, and it helps maintain our form and structure. So to help further explain this theory that I'm going to dive into, I want to talk about tensegrity, and specifically the body as a tensegrity structure. So the way that we're taught about the body, we think of it as, stacking bricks one upon the other to make a house, right? And so the structure is formed by compression. So we think like the spine, each vertebrae is stacked one on top of the other. Each vertebrae is compressing it, and that's what gives it the structure. But in reality, I'm going to go to this video. Tensegrity is more representative of what the body actually is. So we can see this structure here. This is Thomas Myers, by the way, the inventor of anatomy trains. We can see that each of these rods are connected by strings, elastic bands, and none of the rods actually touch one another, but the structure still has form. So it's a structure that's integrity relies upon tension, hence the name. And so you can see here when one part of the structure is interrupted or one line is shortened, it affects the entire structure as a whole, and the whole thing starts to deform. So this is important when we're talking about the myofascial lines, because this is the basis for it. So the functions of a tensegrity structure, the features, is that it's adaptable, it's resilient to deformation, especially when it's strengthened, and it helps to distribute strain. So when I say resilient to deformation, if we take that structure and we start to compress it in, all of a sudden it becomes harder to move each individual part. So if we can train our fascia to be stronger and our lines that we'll go into, we're more resilient to anything that could throw off the balance and our equilibrium that the lines create. And so if we think about that structure, the bones would be the rods that compress or push out, and the myofascia is what tensions everything together and pulls it in, and that's what gives it the form. So the myofascial meridians theory, it's our map to the body using myofascia, so muscle and fascia. It creates a holistic view of the body so that when we're looking at the body and we're looking at someone's pain, so let's say someone has a pain in their hip, we're not just focusing on in the hip, we're seeing, okay, what's going on down at the foot, for example, and we know that, if someone's foot is pronated, that is linked with internal rotation at the hip. Same thing if it's supinated, it's linked with external rotation. So we already have this basis to go upon, and this is just furthering that knowledge that we have. And again, this can provide an explanation for how one area of injury or trauma to an area of the body can lead to dysfunction further away. And so this theory is based on the fact that there are longitudinal connections of myofascia that run interrupted throughout the body, and tension is transmitted throughout the different lines. So these lines, they provide support, dynamic support specifically, as well as control and coordination. They're used in everyday movements, very functional activities. We use them all the time without thinking about it. And these natural patterns that our body have, they're linked to these myofascial chains. So if we're looking at the lines and we find that one line is overactive or one area of the line is tighter or weaker than another, it throws the whole system off, just like that tensegrity structure. So learning how to be able to read the lines and see, okay, maybe this area of dysfunction is causing, the whole system to be thrown off. That's what the basis of this theory is about. So the confirmed lines that we have through systematic reviews as of right now are the superficial back line, back functional line, and front functional line. We have strong evidence for those. And then there's moderate to strong evidence of parts of the spiral line and parts of the lateral line. So we'll go into those ones in detail, and I'll touch upon some of the other lines too, because I think that they're relevant, and I think that it will tie everything together nicely. So the superficial back line, here on the right is a dissected view. So this is what we mean by uninterrupted chain. We can see that all the way down from the plantar fascia to the epicrenal fascia, which is like the scalp essentially. It's one uninterrupted line that's connected. So starting at the bottom, we have the plantar fascia. And when we think about plantar fascia, we're thinking about, springs, tension that is loading and unloading frequently throughout the day. And it's used in a lot of walking and just running in general. So we know that superficial backline has a big role in that. Next up, it's connected at the Achilles tendon to the gastrocnemius. From there, it goes up to the knee, where it connects to the hamstring muscles. Once it gets to the proximal part of the hamstring muscles, there's this little ligament called the sacrotuberous ligament. From there, it crosses and attaches to the erector spinae group. And that's what travels all the way up to the head. So that's what's connecting, upper body to lower body, essentially. And so when we think about the superficial back line, our main role in deciphering what it's about is posture. So these muscles, especially, erector spinae, they're powerful muscles, but they're also, these postural muscles that are on all day. So dysfunction in the superficial back line, so areas of tightness, overactivity, they can lead to issues like increased lumbar lordosis and anterior pelvic tilt, especially the erector spinae group. but it's interesting too because the hamstrings pull into a posterior pelvic tilt. So we're also looking for dysfunction within the line. And so they can also lead to a dorsiflexion limitation. If your calves are very overactive and tight, that can lead to dysfunction there. And as well, forward head posture, just by the way that the erector spinae pull the head into extension. So when we're talking about strengthening the lines, the Romanian deadlift is one of my personal favorites. We're essentially lengthening every part of the line and then contracting it when we stand back up from this position. So this is a really good one to help build up those postural muscles. Something like this we could use as kind of an in-between between like a prone on elbows or a prone press up to like a standing extension exercise. So we're still prone, but we're contracting all the muscles of that line. And we can see when it's contracted, it almost looks like this bow shape. So that's important to recognize when you're looking for, parts of overactivity at the line, what is happening along each part. And so if we wanted to stretch and help mobilize the line, a lot of yoga poses are really good for this. So downward dog and a forward fold, those are two very common poses, but you can see that how that would affect every single part of the line. So moving on, we're going to talk about the back functional line. So the back functional line, it forms an X in the body, and it's used for a lot of athletic activities and functional activities, as stated in the name. So we're going to start on the right here. So it attaches to the arm. So this is something that attaches arm to leg. So we start with the right latissimus dorsi. It attaches to the thoracolumbar fascia, and then that in turn attaches to the contralateral glute max, where it goes down to the femur and connects with the vastus lateralis of that same side. So if we look at it this way, line here, forms an X, helps provide dynamic rotational support, and we'll see there's a spiral line too, and that works together with that, as well as a front functional line. So back and front functional lines, both frequently used in athletic activities, like I said. Throwing, so the back functional line is important for decelerating throws, as you can see connected here. And when you're in that throwing position, usually like the left leg would be forward, and then you're rotating, and that right arm would be tossing the ball through if you're right-handed. So, at the end of that position, there's tension on the lines, the back functional line specifically. And so, if we have dysfunction along this line, it can lead to injuries if we're not able to, like I said, slow down that control of throwing. So it could lead to injuries in the rotator cuff, for example. So some stretches for the back functional line. We have a child's pose stretch here, also very common exercise. We can see that here, stretching the quad, glute right here, and then lat over here. And the first thing I thought of when I saw the back functional line is that, okay, these are very, very powerful muscles, like some of the biggest muscles in the body, lat, glutes, and quads. So I thought of just like a squat jump. And we can see here when they go to load this and they're storing up all this energy, okay, that's tension, and that's tension right at the lats, especially if your arms are up overhead too. And that's how we generate so much force. You see when she's pushing off, she's in this, you can call it like a triple extension, so knee extension, hip extension, and shoulder extension too. So all of those are contracted. So just important to think about when we're thinking about what exercises that we want to give someone to help this. It's functional line, so it should be functional exercises. And I like this stretch a lot too. So we can see that, they're in knee flexion, they're in hip flexion, and their arm is up overhead. So we're getting good tension throughout the whole line. And this is separating out individual lines too. So this is the left back functional line that we're stretching here. And you could turn this into a strengthening exercise by just having this be a cable and then rowing it down or doing like a lat pull down variation. I really like that one. You get a really good stretch on your lats, and it just helps to increase tension along that line and increase that resiliency to tension and building up power as well. So next up, its counterpart is the front functional line. So here we can see another X where we start at the arm again with the pecs on the other side, where it crosses over, goes down the rectus abdominis, and then links up with the adductor longus, where it connects to the femur. So, like I said, this works in tandem with the back functional line for stabilizing, activities during throwing or kayaking. If you're doing a kayak, you're using both lines together, and they're just synchronizing. Again, any rotational exercise is gonna, in some way, incorporate the front and back functional lines. One exercise I really like for this too is right over here. Have the patient in a 90-90 position like this, and I like to have a foam roller in between their knees while they're doing this to get that adduction component. So what they're going to do is press one arm down, basically a single alternating chest press, single arm. So this will help pec, and then you're resisting that rotation, so you're getting some abdominal work as well as just isometrically holding. And then, like I said, that foam roller will get you the adduction component as well. That being said too, we want to work more functional exercises. So obviously, unless you throw javelin, but it's any throwing motion in general too. You can see how the front functional line is being stretched here. And then that contralateral back functional line is that's being shortened. And then when you go to throw, they switch. Okay, so you're building up tension one line and then releasing it. And then here in this picture, we can see that he's rotating towards the ball, incorporating that front functional line. And then when he's winding up, he's contracting that back functional line and getting tension in the front functional line. And then once he has that tension, he's ready to use it. That's when he activates. So when we're doing a full stretch throughout the line, that's when we're getting the most tension. So throughout everything that I'm talking about here, tension is the number one takeaway. That kind of controls everything. So it's just a balance of tension throughout the body, and just seeing how our body uses tension in different movements. And so if there's a dysfunction with the tension, using the Anatomy Trains map, that's how we can hone in on where the dysfunction is coming from. So some of the other proposed lines that we don't have like current scientific literature on are the deep front line and the arm lines. So I'm not really going to go into too much detail, but there's pictures here if you want to take a look at it. The basis for the deep front line is that it's using these deep core muscles that provide us with the stability that lets us use distal mobility. So it's that proximal stability leads to distal mobility, which would be the arm lines. But for example, like the transverse abdominis is here, these adductor muscles that provide stabilization from the pelvis to the femurs, hip flexors, quadratus lumborum, even the diaphragm as well. So moving on, we're going to talk about the superficial front line. So superficial front line, we're going to start here with the toe extensors and the tibialis anterior. So this is the counterpart to the superficial back line. And from the tibialis anterior, we move up the lower leg to the knee where we cross using the patellar tendon. From here, it links up with the quadriceps muscles. And there's a little disconnect. So when the author was coming up with this line, it was more of a functional connection as opposed to anatomical. Like obviously this doesn't connect to this, but functionally they do work together. So once we get to the pelvis, Then we go up using the rectus abdominis again. And then here, I didn't even know that the sternalis was a muscle. And it's only in a certain amount of people, but we do have a lot of sternal fascia here, and that can get really bunched up and concentrically tight in people that slouch a lot and have this, thoracic kyphosis where the pecs are pulling in here. Everything's kind of centering around this spot. So doing a lot of work in this area manually, as well as stretching, can make a big difference in someone's posture, more so than working on their back, which we'll talk about a little bit later. So from this sternal fascia, we go up to the sternocleidomastoid. So obviously, if sternocleidomastoid's tight, that's going to lead to that forward head posture. And some of the dysfunction and also, sorry, it goes up to the scalp fascia behind here, and it kind of loops around, and that's when it connects to the other side. But when this is overactive, we see forward head posture, we see thoracic kyphosis, and also this kind of like posteriorly tilted pelvis. So basically someone who's slouched forward. That's a common thing to see. We can also see some knee hyperextension with this too. So looking for that is kind of a roundhouse point where we can see that, okay, there's an imbalance between the back line and the front line. And also up top here, this is a common place where we'll see one line is, from here to here, it's just shortened and everything is pulled forward. So you'll see a head that's pulled forward and a pelvis that's kind of tipped forward and everything here. And all this is stretched out, where it should be the opposite, where this is nice and strong, keeping us upright, and then we have good length through here. So the balance between the superficial front line and the superficial back line is going to be really important to keep in mind when you're doing this kind of analysis on someone. And so some basic exercises, I like push up, right? We're getting all of that front line activated as a strengthening exercise. More importantly, I would say, is the stretching exercises. So we can see with this yoga pose, this half kneeling, I'll just say front body stretch, even down to the feet, we're stretching that tibialis anterior, stretching the quads, getting a good stretch through the rectus abdominis, and then even the sternocleidomastoids. And obviously keeping that kind of neutral head position as opposed to just tilting the head up, because that's just going to further accentuate the sternocleidomastoid's use, and we want to stretch it out. So going into the spiral line, this is my personal favorite line. It provides dynamic rotational support throughout the whole body. And at first glance, there's a lot going on here. We're doing all these spirals and these helixes around the body, but just looking at it, you can see how much support that this is giving just to someone. Like if we just had this as structure, like you can see how like that could provide a fair amount of support. Maybe not so much at like the knees, since the only one that's really crossing here is the TFL. If we had some quads there, maybe it'd be a little bit better. But I mean, everything's connected there anyways. So with the spiral line, we're starting off with splenius capitis and cervicis. And then from there, we're going to go down, cross over the spine, and we're going to link up with the rhomboids. And so the book makes a point to emphasize that the rhomboids and the serratus are essentially one muscle. And the only thing that's separating them is the shoulder blade. But in this dissected view, this is where the medial border of the scapula is. And when it's taken off, there's really no like discernible difference between one muscle and the other. They're really, like, you can see how connected they are, especially in just this dissected view of everything. So keeping that in mind when we're looking at imbalances, especially on that back side, if one shoulder is kind of pulled forwards more than another, which is a common thing that we see, it's that rhomboserratus muscle that we're really looking at. I see common like points of dysfunction there. So from the serratus, we can see those jagged serrated lines. They link up with the external oblique. From here, cross midline again, and it links up with the rectus abdominis and then the internal oblique of the contralateral side. So already we've done 2 rotations around, I guess, yeah, 2 crosses over. From here, we shoot down using the TFL and the IT band. This leads us to the tibialis anterior, and then that stirrup of the foot that we learned about in school, that is connected through the spiral line. So tibialis anterior meets up at the bottom of the foot with the fibularis longus. From here, we take that pipeline up the biceps femoris of the hamstrings, and it crosses over again, surprise, and it goes up the erector spinae group. Okay, so there's some overlap between erector spinae in the spiral line and in the superficial back line, but functionally they're connected here, and we can see it in the exercises that we do. So I highlighted one. This is me doing one of my favorite exercises. I call it kind of like a row, like a rotational row to press. And what I usually do this for is patients who have neck pain or tightness in that rhomboid serratus area. It could also be really beneficial for improving hip internal rotation in some patients. So what I like to do is just have them leaning over. It could be a bench, a chair, table, it doesn't matter. But they're pressing through the chair to help push their body up as they row. And it's important to have the patient look at their hand the whole time they're doing this, because that'll incorporate the rotation of the head. From this rowed up position, I'll have them actually punch their hand up towards the ceiling. And I usually do this with like a 5-pound weight. And then I'll have them look at their hand. So you can see how this is incorporating the whole spiral line, right? All those different parts. My head's turning up, and then, that's contracting. It's coming around my body all the way down here where it loops back up, around, and through. And so this is one of my favorite spiral line exercises, period. It helps with patients for, like I said, just determining which side is overactive compared to the other side and which side needs more work. And I often find that there is definitely some imbalance when they're doing it. One of the most common spiral line activities is going to be a golf swing. So you can see Tiger here going in for his backswing. He's just loading up that entire spiral line, except for the head. That's why I like incorporating the head in here, because when you're doing something like that, you have to golf swing, you have to keep your eye on the ball the whole time. So your head's staying down, 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 down until that very end point. So I've had myself neck pain on the right side from what I believe is just that disconnect from doing the swing, and I'm not incorporating my head into it. So doing exercises that make up for it, like the side-lying or thoracic rotation as well, moving your head, following your hand, those are really good for helping mobilize the line. As well, you can see that back functional line, see it active here, that lat, along with the glute and the quad. So, that was tensioned. And now they're kind of using that tension and using it to gain power. So already we can make some connections, as well as, on this side, on the front side, that front functional line is being stretched out too. So in this exercise, this can help for that lower body mobilization too. So we have this 90-90 position with the legs. And then to add to this, I like to extend this right arm out this way. And then that incorporates even more of a lat stretch and just this side body rhomboserratus, trying to drop this shoulder down and then turning that head to the left as well. So next up, going to the lateral line. So the lateral line, we can think of that as the side supports to the body. So the superficial front line, the superficial back line, those are providing obviously front and back support, and this is our side to side, our horizontal support. So when we're looking at this, you can view it as a Y here, and then a series of X's going up. So the Y starts at the fibularis longus and brevis, where it meets up with the IT band, the TFL, glute med, and glute max. So this is that Y. From the iliac crest, we connect with the internal and external obliques. That forms our first X. Moving up from the rib cage, those internal and external intercostals. So this is something that's connecting even breathing to, the position of our foot, and vice versa too. How it's affecting, rib cage expansion. Where is the tension at? So someone's having, say, scoliosis, for example, or they're dealing with like compressed rib cage, seeing how that alters the position of the foot or the head, for example. Is their head tilted to one side? Is their rib cage shortened? Is this space shortened relative to the other side? That's the kind of stuff that you're going to want to look at with the lateral line, especially like a Trendelenburg gait too. That would be doing like more of a dynamic analysis. And so some of the easiest ways to strengthen the lateral line would be, this would be a more advanced progression, obviously. So you could do like just the knee for this side plank. But even we're getting both lines active here, which I really like it for that, just kind of balancing it out. Obviously doing it on both sides too, if there's, insufficient strength on either side. And for mobilization, I like this side body stretch because we're getting this supination of the foot too. So we're really stretching out those everters. And then traveling up the side, we're stretching out this common area of dysfunction, because the iliac crest is an area where we see a lot of fascial attachments from various different lines. So focusing on stretches for there and mobilizations, like soft tissue mobilization there, can make a big difference for a lot of patients because of how much mobilization you're getting and how much you're loosening up from all the different lines and kind of clearing up that space and allowing it to glide better. So speaking of, manual techniques, this one in particular is good for people who have some dysfunction in their back, so maybe some increased lordosis or kyphosis, and really for people who don't get their spine kind of moves in one piece. So when they go to bend over, there's not a lot of segmentation that's happening. It's really just moving together as clumps. So what you'll have the patient do is slowly bend forward to try to move one vertebrae at a time as they flex their spine. And then what you're doing is seeing where does it clump together. And so this is telling me that there's some fascial tightness and adhesions going on there. And this is where you want to focus your body work on. So once you've kind of figured out where those clumps are and where the spine isn't moving segmentally like it should, you have the patient come back up, and about 3 to 5 times you have them do it as you bring you can either do fingers, a loose fist, knuckles, or your elbow along either side of their spine. And so when there's an area of kyphosis, that's going to push the fascia out, because your spine is kind of protruding and it's spreading all that tissue away. So your job is to help push it back in as they are flexing forward. And this can help to improve the ability for the fascia to act on each individual vertebrae, as opposed to just being kind of locked up and moving as one part there. And you do the opposite where there's lordosis. You spread the fascia apart, because you can think of the lordosis as the curve is going into the body. So that fascia and all that tissue is kind of covering it up. So you're helping to spread that out. So you have them do this 3 to 5 times, and then you assess their vertebral movement after. Hopefully it's better if you did the mobilization correctly. So when you're thinking about manipulating fascia, you're doing it to restore glide and hydration to the fascia. So it doesn't mean drinking a lot of water. It means moving like there's a wave in front of your fingers. So if you were to put your finger on your hand right now and push in, right in front of your finger, you'll see that there's a little bit of a crest. And if you slowly move your finger forward towards that crest, it'll start moving in front of you. If you were to go too fast, you're going to go over that wave. And so that wave represents mobilizing fascia, right? If we can push that wave at the right speed and the right depth, that will help to get the tissues hydrated, the fascia hydrated, and help restore glide so that it can move better over the muscle and in between the different layers. So that is one of the main ways that we're going to help restore that the movement properties of fascia, so that it's the most efficient. All right, so for your clinical applications going forward, we can call it body reading or postural assessment. We're essentially just identifying which areas are locked long or locked short. So what I mean by that, locked long is somewhere where it's eccentrically tight or stretched. So these areas tend to be the most painful. We can think of this as like the upper traps or the rhomboids. So even though like work on that area feels good for the patient, if we think about someone who has this kyphosis and their back is already being stretched out like crazy and there's all this tension there, if we go in and help to relieve some of that tension by lengthening the muscle out, we're essentially just making the problem worse. And we're creating an environment where there's just going to be more tension and more issues, and it's going to lead to even worse posture. So even though the patient might not feel that like even tightness or any pain, it's usually that there's not that much concentric pain that happens. It's the eccentric ones that are the most painful. But those are the spots that we want to work on, because that will create the most change, and that is the places that actually will benefit from lengthening and restoring the glide too. So another clinical application, this is just a systematic way of seeing the body. Like I've said, we can use it in a gait assessment. So whatever lines are tight, that can result in certain gait abnormalities. Like I said, there's that Trendelenburg gait. In addition, a tight lateral line can contribute to more foot pronation on one side, as well as some imbalances with a spiral line. So you kind of have to be creative and start looking at the body through these lines and in a different way. But as we saw with, the golf swing, it's there. We know the anatomy. It's just putting it all together. So I think practicing when you're doing a gait analysis or just postural assessment with patients and just studying how they're presenting in terms of the myofascial arrangement, shall we say, or like the tension balance between the different lines, that's going to give the most insight to how we can treat the patients properly. And where, if they say they have pain in one area, it's important to recognize where they say it, but also to not rule out that it could be coming from somewhere entirely different from the body. So using these lines to our advantage through that and helping educate the patients going forward, that can make a big difference in our quality of care. And that is all I had for today. Thank you.